sarcopenic obesity. As we all know that after COVID, post-COVID, there is a lot of loss in the muscle mass observed. So there is a tsunami. There are multifactorial causes for sarcopenia: neurological decline, hormonal changes, inflammatory pathway activation, declines in activity, chronic illness, fatty infiltration, and poor nutrition. So, as Vibhuti has already told us that around 50% of people are getting sarcopenic day by day. Now we are coming out of the ICU and I am talking about the daily life. Okay. So, there are certain things where we have the diagnostic approaches. One we missed is ultrasound. It has the advantage of being able to evaluate both muscle quantity and muscle quality. So how does sarcopenia affect your body? So less muscles means greater weakness and less mobility, both of which may increase risk of falls and fracture. So sarcopenia can lead to increased adiposity, insulin resistance, and chronic inflammation, and thus predispose adults to developing cardiovascular events. Chronic inflammatory state, malnutrition, and decreased physical activity observed in cardiac patients are precursors to a catabolic state, leading to accelerated muscle loss and development of sarcopenia. So why? It is all because of malnutrition and decreased physical activity. So there are some hormones which are also responsible for sarcopenia. So first is the testosterone hormone. So low level, and they increase the fat mass, reduce strength, and slower regeneration. That is why, sir, decreasing testosterone level, they add to the adiposity. Then growth hormone, IGF-1. So low IGF-1, it gives impaired satellite cell activity and protein synthesis. Estrogen, as in females, postmenopausal, estrogen decline in women can accelerate muscle loss. Insulin. Insulin resistance reduces anabolic signaling in muscle and common in elderly, diabetics, and obese individuals. Thyroid hormones. So in sarcopenia, both hypothyroidism and hyperthyroidism can cause muscle weakness and atrophy. Cortisol. So it is a catabolic hormone, increases protein breakdown in muscles. So chronic high cortisol, like from the stress, illness, steroid use, promotes muscle wasting. So what is sarcopenic obesity? So we all know, since we are talking about it, that this phenotype poses a higher risk of adverse health outcome, including metabolic complications, falls, and functional decline than either obesity or sarcopenia alone. Clinical risk and consequences are cardiovascular disease, cancer, type 2 diabetes, osteoporotic fractures, frailty and falls, hospitalization and complications, and increased morbidity and mortality. Some changes that occur in adulthood in body composition. In the last CNE, what we did was with in body. Okay, so everyone there had the chance to assess their muscle mass. So there is increase in fat mass and visceral fat, decrease in lean muscle mass, that is sarcopenia. Sarcopenia accelerates with a decrease in physical activity, and then it comes to sarcopenic obesity. So what are the corrective measures? Nutrient dense foods to meet protein intake, weight bearing exercises that Nisha madam will tell you. Recommendations are more than 30 minutes of moderate physical activity on 5 or more days per week. So this is a major slide. What happens once there is sarcopenia? So tissue level changes. Obesity makes fat tissue grow and causes inflammation by attracting immune cells, that is macrophages. This increases harmful substances called TNF-alpha and interleukin-6 to release. Fat cells release more leptin and less adiponectin, disrupting normal hormone balance. These changes affect the brain, liver, pancreas, and muscles. In the brain, they increase hunger and reduce energy use. In muscles, especially weak ones, They cause insulin resistance. Aging and obesity together lower metabolism, increase fat in muscle, cause inflammation and reduce muscle strength, leading to sarcopenic obesity. So what is the treatment and management? Physical activity, increase total protein intake. So here we have 1.2 gram per kg. Now this person what I am talking about is a normal person walking to the clinic. Here I am out of ICU. So I can start with the protein as directed. 1.2 is the basic. We can go up to 1.5. So therapeutic strategies are there: calorie restriction, high quality protein intake, aerobic exercises, resistance training, and all these will be given by Nisha. Then what we need, how do we tackle sarcopenia? We all know that metabolism takes place in mitochondria. Okay, so muscle cell has the mitochondria. So where healthy mitochondria are key to both athletic performance and metabolic health. While glucose can be metabolized in multiple different ways, fatty acids can only be converted to energy in the mitochondria. So typically someone working at a lower relative intensity will be burning more fat, while at higher intensities they would rely more on glucose. Somebody running a sprint, he requires a lot of glucose. And somebody walking in a garden, okay, at a speed of 5.5 kilometer per hour. So he will burn more fat and will rely on the fatty acids to be converted. So what will give the best result? Sprinting. Once we are looking for the sarcopenia and we want to have a fitness level, how do we go about it? It should be steady exercise. See, we do not want to elevate the heart rate to an extent. First of all, the muscles are not there in proper shape. We do not want any kind of jerky movement, sudden sprint, because it will give a chance for injury. We do not want it. So that is why start slow, do a regular kind of a walk, and then we can come up with strength training exercises. So the basic is, now the pharmacological treatments, there are myostatin inhibitors, enamelorine, vitamin D, testosterone, and SARMs, which bodybuilders use. We are not using in the clinical practice. Weight loss medications, Rybelsus, GLP-1, Wegovy, they are all in the market. Antioxidant therapy, that is astaxanthin. It helps reduce oxidative stress and inflammation, supports mitochondrial function, and may protect muscle tissue from aging-related damage. ACT, RI, so a target for therapies aiming to block muscle loss, signaling like myostatin and activin. So these are the proteins which are responsible for the muscle health. So nutrition is the key: preserving muscle mass, supporting metabolism, reducing inflammation and oxidative stress, balancing fat loss with muscle maintenance. So we need an integrated approach: high protein diet, moderate energy deficit to promote fat loss, resistance and functional exercise to enhance strength, mobility and physical function, ONS, that is oral nutrition supplements fortified with key nutrients, antioxidants होना, omega-3, essential amino acids, astaxanthins and all. So protein needs we have all discussed. It is 1.2 to 1.5 gram per kg body weight. Now what are the impact of inadequate dietary protein intake? So it challenges the muscle and whole body protein balance. So protein breakdown is not equal to protein synthesis. In the absence of sufficient dietary protein intake, muscle is catabolized to provide amino acids to allow for continuous endogenous protein synthesis in critical physiological tissues and organs. So your body only starts giving protein by degrading the muscle. That is how the sarcopenia occurs. Then negatively impacts muscle mass, function, adaptations to exercise and bone, disrupts calcium homeostasis, immune system response, fluid and electrolyte balance, enzyme production and activity, and hormone synthesis. So now this question comes up, what do we follow? RDA or estimated average requirements. Nowadays we are having EAR, lowest possible, किस पे काम चल सकता है? काम चल सकता है कि disease को बचाना है. So we have a conflict with the RDAs being given nowadays, which says 46 gram protein is good enough for a day, but it is just for the survival. Okay, we people are functioning well, and we are active population. We are working. So do we have that much amount of protein just to avoid say or to live? बस जीने के लिए इतना काफी है. हम जी रहे कि हम जीना और अच्छे से चाहते हैं या हमारा बुढ़ापा बहुत अच्छे से जाना चाहिए. Okay, whatever we do not want to end up in something called frailty at the end of the day. Okay, so internationally recognized professional organization recommend protein intake on the order of double the current RDA for physically active individuals, including the joint recommendation to consume protein between 1.2 to 2 gram per kg. और कितने सारे लोगों ने इसको ओके किया है. The International Society of Sports Nutrition also recommends protein intake at levels higher than RDA for physically active individuals. The definition of the protein RDA itself draws criticism, given that it reflects the minimal amount of protein required to prevent deficiency, rather than an amount which may allow for optimal health. The AMDR, that is acceptable macronutrient distribution range. It also says it does provide for more flexibility in dietary protein intake recommendations in the context of complete diet, yet most American adults habitually consume protein on the lower end of this range. So this question always comes up, high protein लेंगे किडनी बैठ जाएगी. हाँ, कभी बैठती है? Once there is established renal disease. Okay, so increased amino acids, they only have function or they can degrade the kidney function once the renal disease is already diagnosed. Okay, so healthy kidneys are well capable of adapting to protein intakes above the RDA and within the AMDR. The kidneys are faced with increased nitrogenous waste or more amino acids are oxidized for energy or directed towards gluconeogenesis as the relative percentage of energy intake derived from protein increases. Blood urea nitrogen is considered to be a good tool to assess the dietary protein intake status. And current available data suggests higher protein diets do increase renal workload, but they do not negatively impact kidney health nor increase the risk of developing chronic kidney disease in healthy adults. So one more thing is adding creatine to the diet, which boosts the muscle synthesis. So enhances energy production. It is say not so talked about. A role of vitamin D we all know. Antioxidants, we have to take astaxanthin, vitamin E, vitamin C and polyphenols. Omega 3, so anti-inflammatory, enhances muscle protein synthesis. So this is a summary table. You can take a picture of that, see how and role and the key sources. This is all we need to know. ये सब देना चाहिए. Then there is one case study where age 70, BMI 32, a patient having this diabetes, hypertension and osteoarthritis, low muscle mass, gait speed was less, nutritional assessment 50 gram per day, below target. 50 gram भी अपने आप तो नहीं मिलता है. Why? Because if we calculate, it is hardly 20 grams protein per day. Okay, and इसका तो फिर भी 50 है. And then we allowed them with this OMS, HMB, vitamin D, omega 3, Ricosar. This is also a supplement for muscle protein synthesis and resistance training. So, whey or casein protein to support muscle protein synthesis should be done. vitamin D, HMB, omega-3, antioxidants and micronutrient supplementations have to be made. Then strategy is to moderate calorie deficit, utilize validated screening tools. All these ICU people have already told you. Prevent refeeding syndrome and incorporate antioxidant supplements. So key takeaways are sarcopenic obesity is a dual threat condition requiring a comprehensive and integrated approach to care, nutritional foundation to support muscle preservation and effective fat loss. It is essential to combine a high protein, micronutrient dense and appropriate antioxidant supplements, synergistic exercise, resistant training, personalized care. So adults lose muscle mass due to lower intake of proteins in a day. Sarcopenia often onsets during the late 30s. Ensure optimum protein intake by modifications in diet, recipes and different sources to obtain from. All age groups need adequate calorie, protein, fats, vitamin, minerals and fibers to keep up the immunity and arrest muscle loss. Okay. So suppose if 60 gram protein is needed, I don't want any dietitian to prescribe ghee ki sabji roti kind of a diet. How are you going to come up with 60 gram protein with this kind of a diet? What you eat, don't give that to the patient. If at all you have a habit of having sabji and a roti kind of a diet, eat yourself. But don't give the patient. Don't play with the health of the patient. We need to have proper balance of curd, pulses, salad, chapati, rice, everything in the meal. Single sabji roti is not a meal. Not a meal to be given by a dietitian. Okay?
Sorry, just an interruption. Car number 7372. 7372. Anybody having? No car here?
Yeah.
Sorry.
Yeah. So elderly need more calcium, iron, zinc, vitamin A. So my takeaway is to have a balanced diet always. Thank you so much.